Welcome back to Mayo Clinic Radio. I'm Dr. Sanj Kakar.
And I'm Dennis Stoda. Vitamin D, it's found in a lot of foods, including fish, eggs, fortified milk, cod liver oil. The sun, though, also adds to the body's daily production of vitamin D, and as little as 10 minutes of exposure a day is thought to help prevent deficiency.
Well, what's its major role? Well, the major role of vitamin D is to maintain normal blood levels of calcium and phosphorus. Vitamin D helps the body absorb calcium, which forms and maintains strong bones. Vitamin D may also protect against osteoporosis, high blood pressure, cancer, and other diseases.
So we talked about how the sun can help you keep your vitamin D going. But for those of us living in the northern hemisphere during these gray winter days, we kind of have to ask the big question, what's the best way to make sure we're getting enough vitamin D?
Here to talk about vitamin D recommendations, along with other nutritional advice, is Mayo Clinic specialist in internal and preventative medicine, Dr. Donald Hensrud. Welcome back to the program, Dr. Hensrud.
Happy to be here. Thank you.
So what's actually changed regarding vitamin D recommendations? Have they been amended?
They've changed over the years, and it's interesting. There are a couple sets of recommendations out there. The most solid recommendations are from the Institute of Medicine and form the RDA, or Recommended Dietary Allowance. And those are relatively modest, 400 units a day for children, 600 for young adults, 800 units a day for older adults. The problem is if you look at levels among the population, about 20 to 50% of people in various studies have low vitamin D values, depending on how you define low.
That's a lot.
It is a lot. The recommendations, the RDA, was set just for bone health using a very conservative interpretation of the data. As you mentioned earlier, there's a lot of other evidence that's less solid for cancer prevention, for other diseases such as even heart disease, insulin sensitivity, type 1 diabetes. So the Endocrine Society actually recommends 1,500 to 2,000 units a day of vitamin D.
Wow.
Which almost requires supplementation. So there's a wide variability. I recommend people should at least get the RDA, and this is one of the few supplements that I have a low threshold for recommending supplementation on.
So when you mention the recommended daily amount and you mention the units, what does that physically mean when somebody's thinking, am I eating enough vitamin D?
Yeah, there are food sources, but they're not very good sources,
Okay.
which is why we add vitamin D to milk.
Yes.
It's fortified. But overall, our diet doesn't supply a lot. You mentioned in the north, we have lower vitamin D values. There's less sun. People who have dark skin, for example, also absorb less sunlight, less vitamin D from the sun. People who are heavy absorb less vitamin D. So there are multiple things that can put people at risk for lower vitamin D values.
The recommendations you gave us presumably are for adults. Is it different for infants and children?
Yeah, children's a little bit lower, 400 units a day. Adults a little bit more. But again, there's a big difference between the Endocrine Society guidelines, other recommendations, and the RDA.
So being a new parent myself, the last thing I want my children to get is vitamin D deficiency. You talked about fortified milk. Is there a certain amount of milk, for example, a young child should be drinking on a daily basis?
Oh, just enough. I don't think you have to measure it or anything, but just make sure that they have an adequate supply around, and they should do okay.
And you mentioned supplementation. So how do we go about getting our daily allowance?
Yeah, if you really want to be scientific about it, you can measure your vitamin D value, but that costs anywhere from $250 to $300, and vitamin D3 is very cheap. There's also a larger safety factor than we used to think. So 1,000 units a day of vitamin D3 is safe for almost anyone and is a reasonable amount to supplement.
And you mentioned sun exposure. So, for example, in the winter, all of us are cocooned away. But in the summer, we're all out in our shorts. Does that tend to make up for the deficiency that we have in the winter, or?
Higher values of vitamin D in the blood are reported in the summertime, so yes. Now that's a balancing act, as we all know, because increased time in the sun leads to an increased risk of skin cancer.
Yes.
So if you listen to some of our colleagues in dermatology, you never go out in the sun. And that's probably good advice, but I tell my patients, if you are going to be out in the sun long enough to get pink or burned, then it's time to put sunblock on or sunscreen.
What about the other vitamins that we may commonly have deficiencies for?
In terms of vitamins and minerals, iron is a strong one for young women, menstruating women, and for older people, vitamin B12 10 to 15% of people over the age of 65 have very early vitamin B12 deficiency. And so that's another nutrient that, especially in the elderly, isn't a bad idea to supplement.
Why is that important, vitamin B12? What's it needed for?
Vitamin B12 is used in red blood cell production. You can become anemic with vitamin B12. More importantly, it's involved in nerve conduction.
I see.
Untreated vitamin B12 can lead to nerve damage that's irreversible. It's also been reported very early vitamin B12 can lead to depression, memory problems in the elderly. So that's another one of the few that I have a low threshold for recommending supplementation on.
B12, very good. If we wander down the aisle at the grocery store or the drugstore, the aisles are just packed with vitamins, and some are very affordable, some are quite expensive. How do we go about getting the right ones? Because it sounds like maybe regulation for the supplement industry isn't quite as stringent as approving a drug through the FDA.
It certainly isn't as good as pharmaceutical drugs, but they've become better over the years. There's good manufacturing practices. Most people, but not all supplement companies, follow that. With supplements, the bottom line is, though, you can never be 100% sure that what they say on the label is actually in the pill. And in terms of supplements, we've talked about a couple important ones. For general supplementation, vitamin D, vitamin B12, maybe a little bit of calcium, that isn't a bad idea, and possibly fish oils, although the data aren't as strong. But other than that, unless you have documented deficiency, I'm not a big fan of widespread supplementation.
So you mentioned the number of vitamins one should take. So would a daily multivitamin be sufficient?
Good question.
Or should we be buying separate B12?
So it's interesting because if you look at the data on multivitamins, it's not that strong. In fact, there's a population study out of Iowa that showed that people who took different supplements actually had increased mortality, including multivitamins. So I'm not a big fan of multivitamins, and I think D and B12, if people are in the right category, should take those individually.
Are those the vitamins that you take personally?
I don't take B12 yet, but I probably will start pretty soon as I get up in age. Do take vitamin D.
Now, you mentioned calcium. Is that a vitamin or is that a mineral? And what's the differences?
It's a mineral. And vitamins or nutrients are things that are found that we can't make in our body.
I see.
We can't make minerals either. It's just a different form of something. And calcium isn't a bad one because we're kind of borderline on our calcium intake too. Both D and calcium are important for good bone health.
Very good. Dr. Hensrud, thank you.
We're talking about vitamin D and other... Let me do
Just start that again. She'll let it.
We're talking about vitamin D and other vitamin supplements with Dr. Donald We're talking about vitamin D and other vitamin supplements with Dr. Donald Hensrud. Dr. Hensrud is an internal and preventative medicine specialist at Mayo Clinic.
Well, we're going to take a short break, and when we come back, we're going to switch gears a bit and discuss the second edition of the Mayo Clinic Diet Book, and its two phases, lose it and live it. Dr. Hensrud is going to be right back with us. Welcome back to Mayo Clinic Radio. I'm Dennis Doda.
And I'm Dr. Sanj Kakar. We're back talking nutrition and internal preventative medicine specialist, Dr. Donald Hensrud. We've talked about vitamins and supplements in our first segment. Now let's turn our attention to the Mayo Clinic diet.
And Dr. Hensrud, I know you're well-versed in this, so break it down for us a little bit. What does the Mayo Clinic diet entail?
Well, the Mayo Clinic diet is more than a diet, but we use that term because that's how people search for information on weight management using the term diet. But it's a lifestyle change program. We divide it up into two phases, the lose it phase and the live it phase. People want to lose weight. They want to lose weight quickly. So we took all of the things we could find in the medical literature that have some evidence supporting decreased weight, and we throw the kitchen sink at people for 2 weeks. We ask them to add 5 habits, break 5 habits, and there are 5 bonus habits that we strongly encourage them to adopt. In our pilot program, when people did this for 2 weeks, they lost an average of 8 pounds, and most people lost 6 to 10 pounds. So
in 2 weeks?
In 2 weeks. But it's safe because all the habits are safe and effective.
So can you give us some examples of, for example, some habits that we should be taking?
Some of them are very simple. Eat breakfast, for example. That's been associated with better weight management. Eat more fruits and vegetables. Studies have shown that the more fruits and vegetables that people ate, the less that they weigh because they're not eating something else that's higher in calories. Some of the more difficult ones, the most difficult one for people was no eating while watching TV, and you can only watch as much TV as the amount of time you spend exercising.
Oh,
So we're not telling people not to watch TV, but be active if you're going to. The other difficult one was no sugar except what's in fruit. And you realize how much sugar are in different foods that we eat. For example, there's 17 teaspoons of sugar in one 20-ounce soda.
so we have to read labels, essentially, because we're not talking about sugar I sprinkle on my cereal or in the coffee.
Well, we are. Any added sugar.
Oh, all of it.
All of it. But it's
Okay.
only for 2 weeks. And what people said was, I didn't think I could do it, but it wasn't that bad because I knew it was only for 2 weeks, and they felt empowered. They saw the weight come off, and they felt good going into the next phase of the diet, the live it phase. And that's when we take those habits and turn it into a long-term lifestyle change.
So I want to challenge you because my wife and my mother are probably listening to this and saying, I told you so. So, for example, as physicians, we're busy, we leave home early and we don't have breakfast and we just power on through the day. And then we relatively have a balanced diet at the end of the day. And to me, it makes sense because you're not putting the calories in your body, and so you burn it during the day and then you just eat a little bit at nighttime. But what you're saying is that's totally wrong.
It makes intuitive sense what you're saying, but what
Yes.
happens in studies is that they find that when people don't eat breakfast, they tend to make up for it and more later in the day. They don't even realize it. They may be more hungry. The other thing is, if you think about it from a nutritional standpoint for your body, you're fasting overnight, perhaps 12 hours, and the body does good to get a little gas, a little nutrition in it to feed the fire, so to speak, the engines when it revs up.
So does that mean metabolism comes into play? We often hear about you can't starve yourself because then your body goes into a survival mode.
That's true. And I've seen patients who are eating one meal a day trying to lose weight, and their metabolic rate actually goes down when we measure it. The
okay.
body's trying to conserve its energy. So what we encourage people to do, if you're hungry, eat. Just try and eat the right types of foods.
So, for example, you're a very fit and active gentleman. What do you have for breakfast every morning?
Well, before I say that, it's not what I do, it's what the data shows. But I try and practice what I preach.
Sure.
I'll have a whole grain cereal for breakfast. My lunch, believe it or not, I usually have about 3 pieces of fruit, maybe a piece of a whole grain toast with peanut butter. Today I had some red rice, actually, some leftover red rice. In the evening, I try and have a big salad. Do you remember Jethro Bodine on the Beverly Hillbillies?
Sure.
I've got a salad bowl that he would be proud of. It's a huge salad we usually have.
About the size of a bird bath.
Yeah, that's right. Perhaps some fish, whole grain baguette, and some other vegetables, something like that.
And so just to dispel some dogma, should you eat within an hour of when you're going to bed, for example?
Oh,
The main issue is for people who have heartburn or gastroesophageal reflux. They shouldn't eat within about 3 hours of going to bed because they'll get heartburn when they wake up. For everybody else, a calorie is a calorie is a calorie no matter when you eat it. Some very minor differences, but it matters. What happens at night, if people eat at night, usually they're less inhibited, so they eat more, and the types of foods they eat may be more high calorie. But it's more important to eat what you eat rather than when.
And even following this eat when you're hungry kind of a mantra in small meals throughout the day, should we be looking at our total daily calorie intake?
Yes, you're absolutely. It gets down to calories in versus calories out. The way the Mayo Clinic diet works with regard to weight management is by emphasizing low energy dense or low calorie dense foods such as vegetables and fruits. You can get in a volume to make you satisfied, but not a lot of calories. And if you think about it, it isn't calories that fill us up, it's the volume or weight of food. There's the same amount of calories in 1 1/3 sticks of butter as there is in 10 or 11 heads of lettuce
Oh, wow.
or 35 cups of green beans. So it shows when you're eating foods that are very energy dense, like butter, fats, sugar, as opposed to fruits, vegetables, whole grains, things like that, you can get in a lot more calories and not even realize it.
So, Dr. Hensrud, I wanted to get your expertise in the debate, carbs or no carbs. What are your thought processes on that?
You know, it's interesting. Years ago, everything was low fat and you could eat all the pasta you wanted. Then we turned that on its head and everything was high fat, low carb. And now gluten, the protein, is the bad guy. So these things cycle. The way we emphasize, what we recommend are healthy carbs and healthy fats. So if you're eating a lot of whole grain products, brown rice, oatmeal, whole wheat bread, those are good carbs. They've got a lot of nutrients, fiber in them. Same thing with fats. You don't have to go very low fat. In the Mediterranean, it's a higher fat diet with more olive oil. Nuts are very healthy. They've been associated with a reduced risk of cancer, heart disease, and overall mortality. And so eating healthy carbs and healthy fats is the way to go.
So most of the mile markers and following the Mayo Clinic diet are very well explained in the book. But dieting, and just the idea of dieting, sort of turns people off. We think it's deprivation. And I know looking in the book, there are a lot of recipe suggestions in there.
Yeah, the most important thing is how people approach this. And you're right, most people approach it as something that's negative, restrictive, and deprivation. Therefore, it's going to be temporary.
Well, it is. You're telling me I can't eat my chocolate bar. So of course it is.
To have a piece of dark chocolate.
I see.
But you can still, there's a lot of great food out there. We don't restrict any food. We watch the portion size of higher energy dense foods. All the vegetables and fruits people want to eat. And when people get, there's different ethnic foods that have wonderful plant-based diets. So there's a lot of good food out there, and it doesn't have to be a life of deprivation. Many people say when I weighed less, I felt better. And they need to listen to that while they're enjoying good food.
And I know this steps off topic just a little bit, but it's still toward the same goal. Is there any formula for exercise that should accompany the diet recommendations that
Absolutely.
we would receive?
Some of the habits that we change, one is move 30 minutes a day. You don't have to train for the Olympics or a marathon to get the benefits of physical activity. Any activity is good activity. And so we encourage people, and we show them in the book different ways of getting activity.
Now, there are many devices or apps that one can use to track fitness and also caloric intake. Are you a fan of those devices?
Yes, as long as they're used as a tool.
Okay.
Because what happens lots of times, people use only the device, they get used to the device, it motivates them for a couple months, and then it extinguishes and they stop using it. But if it's a way to track the underlying program that they're on and to keep them on track, great.
Wonderful job. Gosh, so many fabulous recommendations in there. Dr. Hensrud, thanks very much for joining us today and bringing us up to date on the Mayo Clinic diet.
Thank you.
We want to mention that Dr. Hensrud is an internal and preventive medicine specialist at Mayo Clinic.